Thanks so much for having me in New Zealand. Very excited to be here. We've got a full week doing these cytology seminars around the country. Bit of background on Dermcare. We are a 100% Australian-owned company, and we've been distributing our shampoo range, starting with Malaseb, for over 20 years in Australia. We were started by a veterinary dermatologist, Ken Mason, who's still the managing director, and he is a veterinary dermatopathologist as well, so a specialist pathologist in skin. We are based in Brisbane. That's where our head office is, and that's where I'm based, although I'm very, very rarely there. Our biggest thing at Dermcare is that we truly, truly believe in best practice and providing products that will allow you to get the best outcomes for your patients and your clients. So we make products that vets need to use, not make products that we want to sell to vets. And in order to get the most out of the products that we have, we truly believe in top-notch diagnostics and wherever possible, getting a diagnosis before we go ahead and select one of our treatment options. So tonight's seminar is about cytology related to dermatology. And what we're going to discuss is how we get from a case like poor Skeleton here, who was a case at the Queensland RSPCA, how do we get samples from him that look like this under the microscope and allow us to reach a diagnosis. A lot of what we go through tonight will probably be just a review for some of you, but we do have some additional techniques included in the presentation that you might not be familiar with. And we understand, we're vets too, we understand how busy practice can be, so a lot of what we talk about is how to do these cytology techniques quickly and make practice more efficient. We'll run through the sticky tape method, cotton bud sampling, impression smears, skin scraping, trichograms or hair plucks, and pustule sampling. The good thing about cytology is that you don't need a lot of equipment, and what you do need is not expensive in order to make a large range of diagnostics. The only thing, of course, that is expensive is your microscope, so do take care of it. Basically, all you need in a cytology kit would be cotton buds, microscope slides and cover slips, tape, blades, Diff Quik stains, paraffin oil and immersion oil. The only thing that you might not be familiar with on this slide is this one here, which is a microfine filter used for filtering your stains so you don't get contamination between samples. And I'll run through how to do that later in the presentation. Everyone here tonight, or each clinic here tonight, will go home with a cytology kit that includes everything that we will discuss tonight, so you can go straight into using these techniques tomorrow. Some additional things that will round out your kit and that we have included for you are gram stains, a stain called toluidine blue, and a stain called lactophenol cotton blue. Has anyone used either of these before? No? We'll run through those. We've also just included some additional things that can really help for ear sampling. So if we have stenotic closed ear canals, we'll use a fine nasal swab for collection rather than a standard cotton bud. And we always have our transport media on hand for when we want to culture ear samples. So bear with us with the videos. There's a bit of back and forth for these. The first one we're going to go through is a sticky tape prep. A sticky tape prep is appropriate in most cases because you can either be looking for a primary condition or, of course, looking for secondary infection associated with another derm case. Are we working? Yep. So we use a clear acetate tape, never frosted, and we want to press the tape onto lesional skin until the tape is no longer sticky, and then we know we've collected a decent sample. Great for alopecia lesions. We place one end of the tape onto a microscope slide, and we simply use methylene blue or stain 2 from the Diff Quik stain. We press it down, wipe off the excess, and it's ready to be viewed under the slide. The tape acts as a cover slip. So you'll notice as we go through tonight, I'll refer to fixative, stain 1, stain 2 when I talk about Diff Quik. So if I say stain 2, I mean blue stain, not the third one in the series. No need to stain with stain 1. You can do, but you will pick up most of what you need to see on a sticky tape prep purely using stain 2. It will save you time. And we never use fixative because it will make the tape opaque and non-sticky. The next one is an impression smear. Very similar to doing a sticky tape prep, but we usually use it where we have suppurative or suppurative lesions or ones that are already oozing. We can also use it on pustules, which we demonstrate in the video. If you already have suppurative skin, you can simply press the slide onto it, the microscope slide. If you have a pustule, you can open it with a small gauge needle, and we simply press the slide down. That's now ready to be air dried and stained with Diff Quik stain. The next one is skin scraping. Again, these are probably all techniques that you use. Skin scraping we use, of course, to look for Demodex mites. We would use a deep skin scrape, which is what we demonstrate in this video when looking for Demodex, or a shallow skin scrape if we're looking for Sarcoptes. In this video, we are just placing paraffin oil directly onto the slide and directly onto the skin. We squeeze the skin and scrape. And to know we've got deep enough for a deep scrape, we're looking for capillary ooze, or just small amounts of blood on the surface of the skin. It's really important to squeeze the skin because, of course, Demodex mites live in the hair follicle and we want to squeeze them to the surface so we can collect them. But there is a study that demonstrates you can squeeze and release and scrape, and that is just as effective as squeezing and holding the skin while you scrape. So in doing the release, you can actually avoid scraping your own fingers. We place the debris onto the paraffin oil on the slide and drop a cover slip over the top. No staining. That's now ready to view under a low power looking for Demodex mites. Another option for looking for Demodex is a trichogram or a hair pluck. So one of the most difficult things when we're scraping for Demodex is using a scalpel blade around the face of a wriggly pup or a bouncy dog. A trichogram's another option, but would not replace a deep skin scrape. So you could use a trichogram if you have a dog that you didn't want to sedate, but if it was negative, you would probably need to go ahead and do a deep skin scrape to confirm. So to do a trichogram, we're taking hair from the edge of a lesional area. Using hemostats, we pull the hair in the direction of growth. And of course, we're needing the follicle to the hair bud to come out with that so we can actually go looking for the mites. We place paraffin oil onto the slide and we lay the hairs into the oil, trying not to disturb the hairs. We want to keep it as it is as we pull it out, because that way, if there's mites present, they'll still be associated with the follicle of the hair. We're just placing it on both sides of the slide there. We drop a cover slip over the top, and again, it's ready to view under a low power. So we can go looking for Demodex mites, but we can also look to see what phase of the growth the hair is in, because that can allow us to determine between various alopecia disorders. So what are we looking for? Demodex mites. So that's a standard Demodex mite, Demodex canis, and obviously it's live. That's fine to see on diagnosis, but it's certainly not what we want to see when we're tracking our treatment. And this video demonstrates its association with the hair follicle, so that's a good place to look for them when you're scanning your slide on low power.
What magnification is that?
10, just lowest power. So there's three forms of Demodex mite that might be involved particularly in canine cases. Demodex canis is the most common. It does cause a folliculitis, and so whenever we're treating for Demodex and we have Demodex canis, we want to be treating the secondary folliculitis as well. In most cases, there's an indication for some appropriate antibiotic, usually cephalexin, because being a folliculitis, it's a slightly deeper pyoderma. You can also use a topical chlorhexidine-based wash like Pyohex to assist with that. Demodex corneum is another form of the Demodex mite, and it's found in scale and tends to be very pruritic, so it's something to consider. The third one is Demodex injay, or the long-bodied mite. Now that one's found in sebaceous glands and therefore can cause an oil slick appearance along the dog's back. So it's quite an unusual one. The techniques for finding them is similar, so deep skin scrape for all of those. Skin scrape would be probably the best form. We can do the hair pluck as demonstrated, and there is a study that demonstrates the tape impression method. So using a clear acetate tape, squeezing the skin, pressing the tape on, squeezing and pressing on again. And we repeat that until the tape is no longer sticky. In the study they demonstrated that a tape impression was almost as accurate as a skin scrape for finding mites. I think the study was slightly flawed because they were very, very clinically obvious dogs with Demodex, so there would have been a lot of Demodex present. And I think if we're the cases that we're often dealing with, sometimes we might only find one mite even on a deep skin scrape. So we certainly, again, would not want to call it a negative result just because we couldn't find mites on a tape impression. And the fourth and most invasive way of looking for Demodex mites is, of course, a skin biopsy. Now, it's not often needed, but I would say that if you're highly suspicious that Demodex is present, but you've had repeated negative results on all three of the other tests, then proceed with a skin biopsy, because you're not going to get the condition under control if demodicosis is mixed. Some of the examples where you might use the skin biopsy would be for certain cases of pododemodicosis. Can be difficult to scrape the feet and get a result. And in certain breeds, a skin biopsy might be needed. In Shar-Peis, they have mucinosis of the skin, which can make skin scrapes unrewarding. And the Scottish Terrier has a slightly different structure to the hair follicle, which can make a scrape unrewarding as well. If you're going to take a punch biopsy, a minimum of a 6mm punch should be taken, and that goes for any derm condition. We showed a video earlier of pustule sampling. Here's a slightly different technique using a scalpel blade for this one. Why do we want cytology of pustules? In order to rule out whether it's sterile or infectious. So we're using a small blade there with the blade facing upwards, and we're just flicking the pustule open and squeezing the contents out. We then use the same blade to collect the sample with the edge of the blade. We can just smear that onto a slide. Always a very gentle smear. We're aiming to maintain the 3D structure of our cells so that it's most diagnostic. That's then ready to air dry and stain with Diff Quik as you would for any sample. Fine needle aspirate, not always related to derm conditions, but certainly a common technique that we need to use in practice. There are many, many different ways to do an FNA. People are surprised by the technique that we use. In this case, we clipped over the top, not because you have to, because you certainly don't, but because it's a very thick-haired corgi and we wanted to demonstrate the technique more clearly. Very simple prep over the top with metho. And we use a 3 or 5mm syringe and a 25 gauge needle. A lot of people use a much larger syringe and a much larger gauge needle, but the key to getting a good FNA sample is to avoid blood contamination, and this is the way that we do it while still getting diagnostic samples. Always take the needle off before you draw back on the syringe to fill it with air. Replace the needle, blow air through the syringe, and gently spread the sample using the edge of the syringe, edge of the needle, sorry. And we did this one because it was a pigmented mass, so you're more able to see the smear. That's far too thick. That will need to be smeared out in order to actually look at it under the microscope. We'll then air dry that and stain it as normal. Ear sampling is probably one of the most common things we do for derm cytology. The most common way is, of course, to use a standard cotton bud. We do want to make sure that we are getting far enough into the canal to pick up a sample of what's the most likely causative organism for the ongoing infection. So to do that, we really need to get to the junction of the horizontal and the vertical canal. So that usually requires that we pull up the ear to straighten that out so we can get down around the U-bend of the ear there. And in dogs that have stenotic canals, ongoing infection or really purulent infections, or very painful ulcerated bleeding ear canals, then the very fine nasal swab is probably a much better option to use than a standard earbud. You can do it blind, which is simply holding the ear and placing the swab down into the ear, or you can do guided, which not only allows you to see to an extent what you're doing, but it also means that you can avoid picking up organisms from the external part of the ear, which are unlikely related to the infection. And that's key if you're collecting something for a culture. This video just demonstrates how to do all of this. Hold your scope, hold up the ear and collect a sample by yourself with just 2 hands. So we hold up the ear and place the scope until we can see what we want to see, and simply spin it round and hold in the same hand that's holding the ear. Seems very simple, but I didn't know how to do that when I got to Dermcare. And again, just from the other side, we hold the ear, place the scope where we want it to be, and spin it round into the same hand. Then we're able to collect our samples using the guided technique. A few hints. When we've collected our sample, we want to roll the sample across the microscope slide, never smear it or rub it onto the slide. As I mentioned, we're really trying to maintain the 3D structure of the cell or the organism. It makes it easier for identification. If you're dealing with a purulent sample, then really pressing and smearing that sample onto the slide can rupture your neutrophils and leave you with a slide full of neutrophilic streaming, which is the purple stripes that you'll see on your slide. I guess the other thing is that pressing down and rubbing the sample onto it can, to an extent, rupture bacteria and whatnot. And then if you're going ahead and trying to gram stain, we won't have accurate uptake of stain. My pet hate is when I see press down onto the slide written L and R on the same slide for left and right ears. If you can do that by gently rolling it, that's fine, but don't use it as a pen to place your sample on the slide. Put the sample on by rolling it across and write L or R on the space provided. If you have a very, very waxy sample, and certainly a lot of these Malassezia ears that we'll see, the sample will be so waxy that you won't get a good uptake of stain. In order to improve your uptake, you can gently heat the sample, and just do that with an open flame. Wave the slide over the top of an open flame, but don't have your fixative open when you're doing it, as it's highly flammable. And you can do that either before you place stain onto the slide, or if you have some stain on the slide, not fixative, you can wave it over the top to get better uptake of stain. And our last hint is to use a microfine filter to keep your stains clean. You can either, if you're using Copeland jars and regularly just dropping slides in and picking them out again, there will be a lot of contamination of your Copeland jars. A study just out of Adelaide Uni Vet School demonstrated Pseudomonas growth in stains 1 and 2 of the Diff Quik stain, and it was quite significant. We certainly don't want to be diagnosing a dog with Pseudomonas in the ear if it's not present. Alternatively, if you don't want to use Copeland jars and filter those out regularly, then simply use dropper bottles to apply Diff Quik to the slides, and they're provided in the kits as well. So to use the microfine, microfine filter, there's a couple of hints for this one. Don't need to filter fixative. Although there can be debris in it, there won't be any bacterial growth. So if it's low, then just discard it and refill. If it's not, just leave it. To filter stain 1, tip the stain into a second container and scrub the jar clean. We normally use powdered Ajax for this. Copeland jars, of course, have ridges in them to hold the slides, and that's the perfect space for debris to accumulate and bacteria to grow. We usually use powdered Ajax. We didn't have any on the day we made the video. So just some sort of cleaning agent, and we scrub the ridges of the jar with a toothbrush. We'll then use our filter. So we draw the stain that we want to filter up into the syringe, and the key point is to make sure that there's no air in the hub at all, or it won't blow through the syringe. The filter will fly off the syringe and you'll end up with stain everywhere. So just no air in the hub of the syringe at all. Now you can use the filter for both stain 1 and stain 2 as long as you do stain 1 first. If you use the filter for stain 2, we can't go back to stain 1. So a better option is to have a filter for both stain 1 and continue to use that, and stain 2. Depending on how often you filter, you can probably get away with using the filter 5 or 6 times until it starts to clog and you can't get anything through. It's 0.2 of a micron filter, so absolutely nothing will get through. Don't forget to scrub the lids. That was a real source of bacterial growth in the study that was done. Is anyone filtering stains at the moment? If you have a case come in and your stains haven't been filtered and you're concerned about contamination, either get fresh stain and use dropper bottles, or you can use old stain but drop it onto the slide using a syringe with a filter attached, and then you know you're going to have clean, uncontaminated samples. Using stain 2 here, you can see how much debris builds up in the Copeland jars. So again, we scrub the jar and filter the stain back through into a clean jar.
Why is powder better than a paste or a cream?
Oh, look, it's just a personal preference. We just liked the abrasiveness of it to really clean the inside of those, particularly the ridges on the Copeland jar. Yep.
How often do you do it?
Well, we filter our stains at Dermcare once a week, but we are doing multiple slides a day. I think for most general practices, depending how often you use your stains, every couple of weeks would be fine. I'd suggest that if you have a particularly nasty ear that you've dropped slides into the stain, that you consider doing it after that as well, particularly a Pseudomonas ear.
Where do you dispose of your used stain? You're getting rid of it?
Yeah, so we dilute it out to a very, very low concentration, and then, at Dermcare we've got a special drain for it, but you can go down the sink as long as it's diluted out, very, very significantly. And that's ready to go. We'll run quickly through the Diff Quik staining method. Most of you are probably doing that to some extent in practice at the moment, but we'll also talk about gram staining, which not everyone is doing, usually because it takes too long, so we'll show you a very quick method of doing it, and we'll talk about some of the additional stains that we've given you in your kits, lactophenol cotton blue and toluidine blue. There's many, many different ways to use Diff Quik. At uni I was taught 5 seconds in the fixative, 10 seconds in stain 1 and 15 seconds in stain 2, but certainly 5 seconds in fixative, 30 and 30, just leaving the slides in the Copeland jars is appropriate as well. We show a couple in this video. If you are going to dip the slides in, it's just important that you're truly leaving it in for at least 1 second per dip, or we're just not getting the same uptake of stain. So we went 5 seconds, 10 seconds just holding it in, but another way is to do the dipping method. We've just combined a couple of methods there. Only rinse on the side or the back of the slide. Don't rinse directly down onto the top of your sample. Again, we're trying to maintain the 3D structure. And we'll wipe the back and the sides of the slide, but not the top. Now, to save time, we don't wait till we've dried off all the water from our sample. We just drop a cover slip straight over the top. It's ready to view. Go. If you have a slide that you're thinking you might want to keep for a longer period of time to come back and review it later, instead of just dropping the cover slip directly onto a wet slide, you can actually put a drop of immersion oil from your microscope on and then drop a cover slip on top. That will hold the cover slip down onto the slide for a longer period of time and seems to preserve the sample for longer. So Diff Quik's often our first line stain that we will use. It's great for identifying malassezia, which is often what we're looking for when we're doing ear cytology. It's good for identifying white blood cell types, but what it's not good for is identifying between different types of bacteria. It stains all bacteria purple. So it can be hard to distinguish short fat rod bacteria from cocci bacteria. It's usually also the first choice of stain that we'll use when we've got a sample via FNA of a lump because of its good cellular detail that it provides. If we find we have bacteria on our slide, having Diff Quicked it, and we want more information about bacteria, that's when we'll consider using gram stain. Now you can't stain over the top of Diff Quick, so always take 2 slides when you're collecting a sample for something in case you then want to go ahead and gram stain. There is a technique for stripping Diff Quick off a slide, but it's a pain and it doesn't work very well, so have a fresh sample ready to go. So gram stain's great for identifying bacteria, but it's not good for cellular detail, so you always use your Diff Quick first. It will stain gram-positive bacteria purple, and gram-positive bacteria in dermatology are almost always cocci. It will stain gram-negative bacteria pink or a pale orange colour, and in dermatology, gram-negative bacteria are almost always rods. So this is how we can distinguish between cocci and short fat rods by the way that they gram stain, whether they gram stain positive or gram stain negative. So in gram-positive bacteria, the cell wall does absorb stain, and in gram-negative bacteria, it does not absorb stain, and we get that light pink or orange colour. And you can see this is to demonstrate here that this is a rod, but so is this, and there's not much difference between these short fat rods compared to the cocci, so gram stain really comes in handy here. The gram staining method that comes along with gram stains when you purchase them is a little bit tedious. It will say stain this one and leave the stain on for 2 minutes, then rinse, this one 2 minutes and rinse, this one 1 minute, don't rinse. Can be quite confusing and can take quite a while. This is the method that we use and get really good results, and it's a lot quicker. We basically apply every stain for 30 seconds and rinse after every stain. So we'll run through this one. So we've got our sample there that's just been air dried. We soak it in stain 1, which is crystal violet, and we let it sit for 20 to 30 seconds. Probably using excessive amounts of stain there just for the purposes of the video, so it's easier to see. You don't have to use that much stain as long as the sample is covered. And you can see again, we're rinsing only the edge of the slide so as not to damage the sample. So it was on for 20 to 30 seconds and rinse. Same for stain 2, Lugol's iodine. Then we use decolorizer. Again, you can leave it for 20 to 30 seconds. We're actually waiting for the sample to run clear in this case. So you can see the blue leaching out of the sample there. Now this is the one that you don't have to rinse after, but it doesn't matter if you do. So if you're worried about knowing which is which, just rinse after every application of stain. And you can see that now it's running clear. There's no more blue leaching out. We didn't rinse there, but we could have. And finally, stain 4, 20 to 30 seconds and rinse. So that becomes a 2-minute process rather than an 8-minute process. Yep.
Is there any rules of thumb about difficult or gram stain? How long
to rush. Yeah, definitely. We'll, yeah, we'll be shaking them, and we'll just be making sure there's not an excess of fluid over the top. It depends. If you've done an FNA, then you really don't want a moist sample because it will wash off in your stain. You really want it to be truly air dried. If you have a really waxy ear sample and preparation, that's ready to go pretty much straight away because it's not going to wash off. It's going to stick to the slide a lot more accurately. The finer that you can get your sample, the quicker it will dry, and that's the case for haematology and FNAs as well. So if possible, we want to see that they're dry. We want to see the moisture come away and that it's truly dried onto the slide because it will wash off.
5-10 minutes.
Sorry?
5-10 minutes.
Oh, well, if it's a fine enough sample, we could be talking a minute. Yeah. So yes, that's reducing an 8-minute process down to a 2-minute process. So really that becomes quite feasible to do in the course of a workup. No one's used lactophenol cotton blue before. This is one technique that would be helpful for identifying ringworm. So when we look at hair shafts via electron microscopy here, this is a normal hair shaft, and B is a hair shaft completely obliterated by dermatophytosis. So when we use lactophenol cotton blue, it not only has an uptake of stain of the fungal elements, but also the damaged hair shaft as well. We would never use this in place of a culture, but certainly if you've had a negative Woods lamp and you're still thinking, well, I think it probably is, I don't know whether to initiate my treatment now or wait for the culture to come back, then you can do lactophenol cotton blue just to give you a little bit more direction with which way you're going to go with treatment. The technique's really simple. We've collected some hair, usually from the edge of an alopecic area in a dog or anywhere in a cat. And we soak those hairs with the stain. Now we do need to heat the sample to allow uptake of the stain. So we drop a cover slip over the top and just hold a lit match underneath. And we know we've heated it for long enough when the sample starts to bubble. We haven't done, we've always just used a single match for it. I'm not sure, you potentially could. I don't know if you get enough direct heat to truly get that bubbling effect, which is that's what we need to know that we've heated it enough. And at the end there, we're just wiping the soot from underneath the slide so it doesn't affect our viewing. Has anyone used toluidine blue? This is actually a stain that's more commonly used in histopathology, but certainly we can use it in cytology. It's good for seeing cellular detail, but its key benefit is that it will stain the granules of mast cells very well. So in this one here, this is a FNA of a suspected mast cell tumour, and we can see that we've got staining of the cells, but it would be very difficult to identify the fine granular uptake of stain. Whereas when we stain it with Tol blue, basically the whole slide is mast cell granules, and that's a pretty unmistakable mast cell sample that we've got there. I don't have a video of the process, but it's simply to do an FNA, air dry it, soak it for 20 to 30 seconds in Tol blue and rinse, and it's ready to go. You don't need to heat that one. So in all these techniques we've been talking about, what are we actually looking for? The most common yeast in dermatology by far is Malassezia pachydermatis. We can also have aspergillus involved in dermatology. Most people are more familiar with nasal aspergillosis in dogs, but certainly in a recent ear study that we did where we had ear cultures sent into Dermcare, out of 150 dogs that had their samples sent in, 3 had a significant aspergillosis of the ear. There are various others. We had 2 candida and 1 syncephalastrum cultured as well. Now, a lot of people might assume that that's just a contaminant, but it correlated with the cytology to show that there were significant numbers of these organisms from deep down in the ear. Aspergillus of the ear will often be present in dogs that have been treated long-term with a polypharmacy, such as a dermotic or something that contains a antifungal element and an antibacterial element, and is often visible as white plaques on the eardrum. They might have no discharge, but just a continual head shake and irritation of the ear. So that's the one we're all familiar with, Malassezia pachydermatis, a dark purple staining oval-shaped yeast or a footprint shape of its budding. And I don't have a slide picture of Aspergillus, but that's an electron microscopy picture of what Aspergillus looks like. You certainly won't see that down the microscope. Which bacteria are we looking for? The most common cocci bacteria in dermatology is Staphylococcus pseudointermedius. Slightly less common, but no less important, are the streptococcal species. So on this one here, we have some Malassezia. This is a gram stain slide, hence the poor cellular detail. But we can see that we've got gram-positive cocci bacteria in groups of 2 or groups of 4, and that tells me that it's staphylococcal species. Strep will stain as gram-positive cocci, but usually in chains or clumps. The rod bacteria that are significant, of course, Pseudomonas, but also the coliforms such as E. coli and Proteus can cause significant otitis externa as well. Again, we have a gram stain slide, and we have gram-negative staining small rods, and that's Pseudomonas on that slide. So in summary of our diagnostic techniques, what do we do and when? If we have lumps or nodules, we want a biopsy using the least invasive technique first, which is of course an FNA. If that doesn't get a diagnostic answer, then we'll move forward with surgical biopsies such as a punch, wedge or excision biopsy. If we have pimples or pustules, don't forget that Demodex causes a folliculitis, so we'll definitely be wanting to scrape for Demodex, and we'll also do cytology on a pustule sample looking for infection. We may need to both Diff, Quik and gram stain to get our answer there. If we have alopecia, again, we'll always skin scrape for Demodex. We'll want to do cytology looking for secondary or primary infection and the presence of dermatophytosis. We may need Diff, Quik, gram stain and lactophenol blue. And we mustn't forget our underlying causes such as fleas, allergies and hormonal conditions. And if we have an ear discharge, we'll want to do cytology, looking for mites, bacteria, yeast and inflammatory cells. And again, we may both Diff, Quik and gram stain in that case. So the next half is on treatment, so we might take a quick break there and come back to that in 5 minutes or so.